I'm going to be talking about a special part of vascular medicine, something that doesn't get nearly enough coverage, and that's this disease called lymphedema. Some of you may actually know someone who suffers from lymphedema. It's a fairly common disorder, and it's something that vascular medicine specialists really try hard to learn more about and treat because in the primary care kingdoms, there's not a lot of knowledge about lymphedema, unfortunately. Can we please get my slides up? Thank you. So I have no conflicts with regard to this talk. And so what we're going to do over the next 10 or 12 minutes is highlight our improved understanding of the epidemiology and pathophysiology of lymphedema. We're going to describe the physical exam and imaging techniques for diagnosing lymphedema. And then we're going to actually review the standard of care and some wonderful advanced techniques for treating lymphedema. So what is lymphedema? Lymphedema is the abnormal accumulation of interstitial fluid. This is like a fluid that's kind of devoid of blood cells, almost like a type of water, and a buildup of fibroadipose tissue, that's scar tissue and fat, resulting from injury, infection, or congenital abnormality of the lymphatic system. So I had mentioned earlier that there are 3 types of blood vessels in the body. Arteries bring blood and fluid to the extremities. Veins take it back, but veins cannot take back all of the volume of fluid that's delivered to the extremities, and for that excess, that's why we have lymphatic vessels. Lymphatic vessels help to bring this interstitial fluid back to our hearts. Lymphedema is classified as primary or secondary depending on the cause and the presentation of the patient. When we look worldwide at causes of lymphedema, the most common cause is infection, and that's most often a parasitic infection. When we look at causes of lymphedema in the developed world, like the US, the number 1 cause would be cancer or cancer-related therapies. Looking at the type of lymphedema that's referred to a vascular medicine specialist or other types of vascular specialists, secondary lymphedema, lymphedema that someone's not born with but actually develops, that's the most common type of lymphedema that is referred. When we look at types of primary lymphedema, the most common type is lymphedema that presents later in life, followed by lymphedema that presents in youth, and then it's fairly rare to see lymphedema that patients are actually born as infants with. Here we can see congenital lymphedema. This is called Milroy's disease. These patients are born with lymphedema. You can see here the swelling of the toes and the top of the foot. It usually affects both lower extremities. It's more common in women. And very interestingly, it's due to a mutation in a gene called FLT4, which is very important for something called vascular endothelial growth factor receptor. And I'm going to show you about why that matters in a second. Lymphedema praecox is called Meigs disease, and this has an onset somewhere around puberty to 35 years of age. We can see here, this is my clinic patient with very dramatic swelling of the hands, the forearms, the fingers, and also the lower extremities. This is due to a mutation in a gene called FOXC2. FOXC2 is very important for the development of valves in the lymphatic vessels. So lymphatic vessels have valves, and if you don't form them, then you're prone to developing lymphedema. Lymphedema tarda is onset of lymphedema after 35 years of age. It most commonly involves the lower extremities, and again, more common in women. And we can see here that the left leg is involved here in this patient. It doesn't have to be bilateral, it can be unilateral, and this is a very nice example of that. So what are the risk factors of lymphedema? For secondary lymphedema, cancer and cancer-related therapies would be first and foremost in the developed world. Things like radiation therapy can scar the lymphatics or damage the lymph nodes. In the developing world, infection is the #1 cause, and this includes filariasis, which is a parasitic infection that's very common. There are other illnesses like recurrent cellulitis or infections of the lymph nodes that can cause lymphedema. Inflammatory disorders such as collagen vascular disease, that would be things like lupus or rheumatoid arthritis. Other things like sarcoidosis can cause lymphedema. Even just obesity can cause lymphedema. We're born with a set number of lymph vessels and lymph nodes, and if we grow to the point where there's more tissue than our lymph system can actually take care of, then we develop lymphedema. And chronic venous disease, having varicose veins for a long time with venous insufficiency, if it goes untreated, can lead to lymphedema. So let's talk a little bit more about the pathophysiology. So in this movie, we can see something very important. We can see that the lymph vessels start from our feet, and they travel up our legs, carrying lymph to regional lymph nodes. The lymph nodes join up. Pardon? Okay. Can you please turn on my lavalier? I'm wearing one. So you can see that the lymphatics travel up through the legs, join at lymph nodes. The lymph nodes form collector vessels that then drain into something called the thoracic duct, and that drains into the heart. So that is the anatomy of the lymphatic system. Now, I mentioned there are a number of genes that regulate the development of the lymphatic system. For the formation of lymph vessels, genes like I'm going to go back here. VEGF, I mentioned, is one of the genes that's implicated in lymphedema. That gene is very important for the development of the lymphatic vessels. Things like FOXC2 are very important for the formation of these lymphatic valves. And then there are other genes that are very important for the formation of lymph nodes. An abnormality in any of the formations of the vessels themselves, the valves, or the lymph nodes can lead to lymphedema. So now we're going to see a little bit about what the lymph nodes do. You can see that interstitial fluid comes out of the capillary and then goes into the tissue, but it's collected into these lymphatic vessels here. The lymphatic vessels carry the lymph to regional lymph nodes. We can see the lymph entering the lymph node here. The lymph is clean, the interstitial fluid is cleaned by the lymph node and then sent out into a collecting duct here. You can see it passing through, being filtered and sent out through the collecting duct. The collecting ducts join up into the thoracic duct, and they empty into one of the veins and then into the heart. So that is how the lymphatic system functions. For a long time, people didn't think that the lymphatic system was an active set of blood vessels. They thought they just were passive conduits. But actually, you can see here that the lymphatic vessels microscopically actually contract on their own. They have a peristaltic contraction that helps to shepherd the interstitial fluid back to the lymph nodes and eventually to the heart. The lymphatic vessels have beautiful but very delicate valves, you can see here, that close so that lymphatic fluid doesn't travel back towards the foot but is continuously shepherded towards the lymph nodes. And then contraction of our skin with just movement, such as walking, also helps to squeeze the lymphatic vessels and, again, pump that lymphatic fluid back to the lymph nodes and heart. So now we're going to talk a little bit about diagnosis of lymphedema. The onset's usually insidious, meaning it's gradual. Symptoms of heaviness, tightness, and aching often accompany the swelling. Range of motion and function can be lost as the disease progresses. You can see here significant lymphedema affecting the left leg. The patient was complaining of heaviness at the end of the day, especially limiting her ability to do household duties. On physical examination, one of the things that can be helpful for diagnosing lymphedema is something called a Stemmer sign. What we do is we try to pinch the skin of the second toe. If we can pinch it, that suggests that there's not lymphedema. If we try to grab that skin and we can't actually tent it up, that's a sign that there's excess lymphatic fluid or interstitial fluid in the toes, and that's a sign of lymphedema. Stemmer sign. We try to pinch the skin on the dorsum of the second toe, and if we can tent it, then that shows that there's not significant excess fluid. If we can't, that means there's a buildup of fluid in the feet. Lymphedema can be staged according to its severity. Here we can see in a patient with stage 0 lymphedema, the lymphatics actually look normal. As we move to stage 1 lymphedema, we see that the lymphatics get dilated. As we move to more severe stage 2B lymphedema, you can see the swelling here. We get contraction of the lymphatics. And then finally, in the last stage, stage 3, the lymphatic vessel is all scarred down and fibrotic. On physical exam, sometimes folks talk about edema being pitting or not. Sometimes clinicians can incorrectly assume that if there's pitting, it can't be lymphedema. But this is certainly lymphedema, and we can get pitting early on in lymphedema before there's significant fibrofatty infiltration. One of the earliest signs, and something that helped me to diagnose lymphedema in a very young patient of mine who'd gone through several providers without actually getting a diagnosis for her swelling, is dystrophic toenails. So dystrophic toenails just simply means abnormal looking toenails. And one of the things we look for is these kind of short stubby toenails that are kind of scooped out. And that can be one of the first signs of lymphedema. The reason you get that is the nail bed develops lymphedema and pushes up on the nail. So that's an early clue of lymphedema. Another thing that is important to distinguish lymphedema from is something called Lipoedema. Lipoedema is a painful fatty infiltration of the lower extremities that sometimes can be confused for lymphedema, but they're not the same thing. Lymphedema tends oftentimes to be unilateral. There's usually swelling of the foot. Lipoedema is more of this sort of fibrofatty tissue that's infiltrated both sides and symmetric. So bilateral and symmetric would make you think more of lipoedema. Also, the cutoff here at the ankles with relatively normal-looking feet is consistent with lipoedema. We have to also distinguish lymphedema from chronic venous insufficiency. Here we have a patient with lymphedema, and here we have a patient with chronic venous insufficiency. The real difference here is oftentimes the toes in chronic venous insufficiency are spared, whereas they're involved, even the dorsum of the foot is involved in lymphedema. And then chronic venous insufficiency has this hyperpigmentation change that you don't usually see with lymphedema unless there's superimposed venous insufficiency on top of the lymphedema. So how do we diagnose lymphedema? Well, sometimes we can just look at a patient and take the history and have a good sense that there's lymphedema. But what we oftentimes have to do is something called a lymphoscintigram, which is a nuclear medicine test. An IV is placed between the web spaces of the toe, and radioactive tracer is injected, and then pictures are taken at regularly spaced intervals, 15 minutes, 30 minutes, 60 minutes, 120 minutes, sometimes hours after, to see how the tracer flows up the lymphatics. CT and MRI are not particularly helpful. They just kind of show nonspecific findings, something called honeycombing. What we really use is the lymphoscintigram. So here, a patient has had their lower extremities injected between the web spaces of the toes with radiotracer. We see that at 5 minutes on the right side, the tracer's starting to go up the lymphatics. On the left side, we don't really see that. At 15 minutes, we start seeing more tracer going up the right side, but again, not seeing a lot of it traveling up the right side. At 30 minutes, we now start seeing some uptake of tracer into the right inguinal nodes, the lymph nodes in the groin. but we don't really see much going on in the left leg. Again, we can see that here in a different projection. At 2 hours, we see that a lot of the tracer has traveled upwards, and there's still a big pool on the left side. Really, none of it has traveled upwards on the left side. Here we can see up high, past the inguinal nodes into the lymph nodes that are in the pelvis. The right side has filled nicely. The left side, no filling of this radiotracer. And then finally, even 7 hours after the injection, we've got a lot of radiotracer in the right pelvic nodes, even up into the abdomen, but on the left side, nothing. And all we see in the left foot is spreading just through the skin of this radiotracer. And so this patient has severe left-sided lymphedema. The lymphatic vessels are absent, and we can't even see the lymph nodes. So how do we treat lymphedema? Well, there's a number of options. It's a misconception that there's nothing we can do for lymphedema. There's actually quite a bit. Limb elevation and avoiding gravity-dependent positions for prolonged periods can help. Diet and exercise, maintaining a healthy ideal body weight is important. Aerobic and limited resistive trainings recommended. And swimming is fantastic for patients with lymphedema because the water actually provides some compression. Skin care is critical. Patients who have athlete's foot or cracks in their feet, who walk barefoot can get cellulitis, and cellulitis damages the few lymphatic vessels that are healthy in their legs, and they develop worsened lymphedema. So we have to prevent cellulitis, and then we have to treat it aggressively at the first sign of it, usually with IV antibiotics. Compression therapy is one of the mainstays of treatment for lymphedema. For more severe disease, we use multi-layer short stretch bandaging. I'm going to show you what that's like. For maintenance, compression stockings work quite well. Home compression pipes can also be helpful. And the other key part of lymphedema therapy is physical therapy. Something called manual lymphatic decompression, a very light type of massage, actually activates the lymphatic vessels and gets them contracting, and that helps to pump the lymphatic fluid back towards the heart. Patients can be even taught to do this at home. So here's an example of that very gentle type of lymphatic massage. It's not like a sports massage. It's just very lightly stroking the skin in a methodical, distal to proximal manner to help activate the lymphatic vessels. And the lymphatic vessels actually keep contracting for hours after this type of massage. The result of manual lymphatic compression is really dramatic reduction in the overall volume of the limb and improvement in symptoms. Here we can see before therapy a very disfigured, very dilated, very heavy-looking limb. After therapy, this has decreased quite a bit. You can see the same here, and perhaps in this projection you can really see how much volume of lymph fluid has been removed by doing this lymphatic compression. The bandaging actually is quite extensive early on. You have to start at the toes and wrap the patient with compression bandages. You wrap then up through the foot, and then you wrap over it with another bandage to start to mobilize the lymphatic fluid from the ankle up, and then you go with an ACE bandage over, and you create this multi-layer compression that helps to shepherd the lymphatic fluid back to the inguinal nodes. Home compression pumps can also help. These are things that patients would wear at home. They inflate in a sequential manner, helping to squeeze the interstitial fluid into the lymphatics, then pushing the lymph fluid up towards the inguinal ligaments where the lymphatic vessels are, and then helping them to drain centrally eventually into the heart. There are surgeries for treating this. The oldest surgery is something called the Charles procedure, which is actually stripping off all of this congested tissue right down to almost the muscle. It does help with the patient's symptoms, but it is very disfiguring, and we try to avoid doing the Charles procedure if we can. There are some fascinating advanced techniques for treating lymphedema that I'm going to share with you. One of them is called lymph node transfer, taking a healthy lymph node, oftentimes from the thoracic cage, the supraclavicular area is a place where there are lots of lymph nodes that can be transplanted. They're transplanted right into the lymphodematous limb, and they help to actually encourage the growth of lymphatic vessels. And you can see here in a patient that had very severe lymphedema, transplant of a group of these nodes has resulted in reduction of the overall lymphedema. This is still an experimental technique, but early on does seem to show some promise. Another technique that can be done is to take the lymphatic vessels and actually attach them to veins. Since the lymphatic vessels may have trouble draining to lymph nodes, you can actually attach them to adjacent veins so that the interstitial fluid, the lymphatic fluid, can drain through the venous system. This is called lymphatic venular anastomosis. And here's an example of a patient that has lymphedema after this type of procedure where they graft the lymphatic vessel directly onto a vein. You see that they've had a nice reduction in the congestion of their lower extremities. Also an experimental technique. One of the most promising techniques is actually liposuction for severe lymphedema. There are an increasing number of centers that are becoming adept at this. What we can see here is a graph of excess volume reduction over time. This is a patient that preoperatively had a tremendous volume to the lower extremity. 2 weeks after liposuction, there's a great decrease in the overall volume. But look at this, it continues well after the liposuction. The volume of their lower extremity continues to be reabsorbed and reduced by the body even years after liposuction. And you can see just what a dramatic contribution liposuction has to resolving this patient's lymphedema. This is very promising, and we're very interested in trials of this. There's a national lymphedema network that provides a position statement on how to take care of patients with lymphedema that you can find on the web at lymphnet.org, and we're very much looking to try to help lymphedema patients as much as possible as a vascular medicine community. So to summarize, lymphedema is a really common vascular disorder that's under-recognized until advanced stages. We want to treat patients early because we can do more for them early. The pathophysiology depends upon congenital and acquired injury to the lymphatics and the lymph nodes. Diagnosis incorporates the careful assessment of risk factors, a comprehensive physical exam looking for things like the stemmer sign, toenails. You have to really have your eyes open for the signs. And then lymphoscintigraphy to cement the diagnosis. And for the majority of patients, a conservative multimodality therapeutic approach with compression and that physical therapy seems to help quite a bit for our patients and is something that we actively offer to our patients in the clinic. Thanks so much, and I'll answer questions now.